Welcome to the channel Language Clinic. We are going to read from Cardiology Secrets. The name of the topic is Heart Failure Long Term Management. There are three writers, Savitri Fedson, Glenn N. Levin, and Baikim Buscott. And the writers are all are professors. Savitri Fedson is MA, MD, Professor, Center for Medical Ethics and Health Policy, Baylor College of Medicine. Professor, Department of Medicine, Michael E. Dekby, VA Medical Center, Houston, Texas, United States of America. And the second writer is Glenn N. Levin, MD, FACC, FASA, Professor of Medicine, Baylor College of Medicine, Chief Cardiology Section, Michael E. Debicki, VA Medical Center, Houston, Texas, USA. And the other writer is Baikim Buscott, Professor, Mary and Gordon Kane Chair and Professor of Medicine, Directors, Winter Center for Heart Failure Research at Baylor College of Medicine, Medical Care Line Executive, the Becky VA Medical Center, Houston, Texas, United States of America. So this is going to be a long video, and in this long video we will talk about all about heart failure and the long-term management of heart failure, and we will talk about almost 37 questions and the answers to these questions. I hope you do enjoy listening to this video because this is a very crucial chapter on heart failure, because anytime people can developmentally develop heart failure, or for some reasons people can develop heart failure. So this is a channel of education and entertainment. So if for your entertainment and education, we are going to read on heart failure, the long-term management of it. This chapter addresses the long-term management of patients with chronic heart failure with reduced or depressed ejection fraction, simply HFrEF, the management of patients with heart failure with preserved ejection fraction, in brief, heart HFpEF, is discussed in another chapter, chapter 23. We have already uploaded this video on heart failure with preserved ejection fraction and heart failure with reduced ejection fraction. So I hope if you did not watch the video, please keep watching those videos for your better entertainment. The management of patients with acute decompensated heart failure is discussed in 26, but still we are yet to upload that video. Later on we will try to upload the video on acute decompensated heart failure. Specific discussions of left ventricular assist device or LVADs and consideration of cardiac transplantation are discussed in chapter 28. We will try to upload the video later on. The roles of pacemakers and implantable cardioverter defibrillators in patients with heart failure are discussed in this chapter, as well as in the chapters on pacemakers, chapter 38. We will also upload the video on pacemakers later on, and implantable cardio defibrillators, chapter 39. We will also try to upload the video on implantable cardioverter defibrillators. Now, question number 1, how are heart failure symptoms classified? The answer is, symptoms are most commonly classified using the New York Heart Association classification system, or NYHA. This symptom-based scale is often how patients are enrolled in clinical trials. Class 1. No limitation. Ordinary physical activity does not cause excess fatigue, shortness of breath, or palpitations. Class 2. Slight limitation of physical activity. Ordinary physical activity results in fatigue, shortness of breath, palpitation, or angina. Class 3. Marked limitation of physical activity. Ordinary activity will lead to symptoms. Class 4. Inability to carry on any physical activity without discomfort. Symptoms of congestive heart failure are present even at rest. Increased discomfort is experienced with any physical activity. Question 2. What is the stage system for classifying heart failure? The answer is in 2001, the American College of Cardiology or American Heart Association, simply American College of Cardiology is called ACC and American Heart Association is called AHA, introduced a system to categorize the stages of heart failure, highlighting the structural development and progression of heart failure rather than focusing solely on clinical symptoms. In addition, the 2013 heart failure guidelines suggested appropriate therapy for each stage, emphasizing the differences in heart failure with reduced ejection fraction and heart failure with preserved ejection fraction and at stage C. There is ongoing discussion about the management of patients with ejection fraction between 40% and 50%. Question, Stage A, asymptomatic patients at high risk for developing heart failure but without structural heart disease. Yes, includes heart disease, structural heart disease includes patients with hypertension, coronary artery disease or CAD, obesity, diabetes, history of drug or alcohol abuse, history of rheumatic fever, family history of cardiomyopathy, and treatment with cardiotoxins. Stage B, asymptomatic patients with structural heart disease includes patients with previous myocardial infarction or MI, left ventricular remodeling or LV remodeling, including LV hypertrophy or LVH, and decreased EF or ejection fraction, and asymptomatic valvular disease. Stage C, patient with structural heart disease with prior or current symptoms of heart failure. Stage D, patients with refractory heart failure requiring specialized interventions. The key point with the stage system is that once symptoms of heart failure develop, the patient is stage C and that there are therapies for heart failure that are indicated in the asymptomatic stage A and B. Try to delay or prevent clinical heart failure. Question 3. Which medical treatments have been shown to decrease mortality in patients with heart failure? The answer is pharmacotherapies that have been shown to decrease mortality in patients with heart failure with reduced ejection fraction include the following and summarized in table 27.1. We will later talk about the table on 27.1. This is the table you can see. We will later talk about it in another video. Renin, angiotensin, aldosterone system blockade or RAAS or RAS blockade. Angiotensin converting enzyme or ACE inhibitors are first line agents in those with decreased ejection fraction because they have been convincingly shown to improve symptoms, decrease hospitalizations, and reduce mortality. Angiotensin 2 receptor blockers or ARBs are used in those who are ACE inhibitor intolerant because of persistent cough or in some cases after an episode of angioedema. The mineralocorticoid receptor antagonist or AMRA or selective aldosterone antagonist or SARA or SARA, spironolactone or eplerenone is recommended as an additional therapy in carefully selected patients with preserved renal function already on standard heart failure therapies. These agents have an additive decrease in mortality in patients with New York Heart Association class 3, 2 or 4, 2 to 4 heart failure symptoms. The combination of nephrilicin inhibition with ARB forms a class of medications, angiotensin receptor nephrilicin inhibitors or ARNIs or ARNIS. There is one currently available, sacubitril and valsartan, simply it is called in brand Entresto. It can be used in patients with heart failure with reduced ejection fraction who are either not already on an ACE inhibitor or ARB or in substitution for current ACE inhibitor or ARB therapy. Hydralazine and isosorbide dinitrate are used in patients who are unable to tolerate ACE inhibitors or ARBs or ARNIS because of renal failure, angioedema, or as a consideration for add-on therapy. Hydralazine, hydralazine and isosorbide dinitrate should be considered in addition to an ACE inhibitor. ARB or ARNI or ARNI in blacks in particular because it appears to have an added mortality benefit and can be considered as an add-on therapy in others if the patient's blood pressure allows. Sympathetic nervous system blockade. The beta blockers metoprolol succinate, in brand it is called Toprol XL, carvedilol it is called in brand Coreg, and bisoprolol in brand it is called Zybeta, have been shown to decrease mortality in appropriately selected patients. These agents should be initiated in euvolemic patients on stable background heart failure therapy, including ACE inhibitors or ARBs. Carvedilol may be preferable in those with higher blood pressures, while metoprolol succinate may be more potent as an antiarrhythmic agent. Implantable electronic devices. Implantable cardioverter defibrillators or ICDs are considered for primary prevention of sudden cardiac death in patients whose ejection fraction remains less than 30% to 35% despite optimal medical therapy and who have a good quality life expectancy of at least 1 year. Biventricular pacing for resynchronization therapy. Biventricular pacing or BIV or cardiac resynchronization therapy or CRT should be considered for patients in sinus rhythm with New York Heart Association class 2 to 4 symptoms, left ventricular ejection fraction less than 35% and QRS greater than 150 milliseconds with a left LBB or left bundle branch. CRT can be implanted with or without a defibrillator. Consultation with an electrophysiologist is recommended. Question number 4. What is the suggested dosing regimen of sacubitril and valsartan? The answer is for patients being switched from an ACE inhibitor to sacubitril or valsartan, the product package insert recommended starting dose is 49 by 51 mg. That means sacubitril 49 mg and valsartan 51 mg twice daily. A washout period of 36 hours between discontinuation of the ACE inhibitors and initiation of sacubitril or valsartan is recommended. It is recommended to double the dose of the drug combination after 2 to 4 weeks to the target maintenance dose of 97 by 130. That means 97 is sacubitril and 103 is valsartan. Mg twice daily as tolerated. It is recommended that the starting dose be reduced to 24 by 26 mg twice daily for patients not currently taking an ACE inhibitor or ARB or previously taking a low dose of these agents. Patients not currently taking an ACE inhibitor or ARB or previously taking a low dose of these agents. Patients with severe chronic kidney disease or CKD, estimated glomerular filtration rate or EGFR is less than 30 ml per minute per 1.73 meter square. Patients with moderate hepatic inflammation, sacubitril or valsartan should not be used in patients with severe liver disease, pregnancy, concomitant use of ACE inhibitors, allow a washout period of 36 hours, and those with a history of angioedema related to previous ACE inhibitor or ARB therapy. Important side effects of the drug combination include hyperkalemia, renal impairment, hypotension, and angioedema. Question number 5. What additional class of medications has recently shown to have mortality benefit in heart failure? The answer is recently the SGLT2 class of medications initially intended to be used for the management of diabetic patients were shown to have significant benefit for heart failure related hospitalization and death irrespective of the presence of type 2 diabetes. Dapagliflozin and empagliflozin have shown to decrease mortality and heart failure hospitalizations. Question 6. Which therapies in heart failure have been shown to reduce hospitalization? The answer is all the aforementioned medical therapies reduce heart failure symptoms and to a degree heart failure hospitalizations. However, the therapies for heart failure are also aimed at symptom management. In addition to diuretic therapy, the following medications impact on the heart failure hospitalization and symptoms. Digoxin has been shown to decrease heart failure symptoms and long-term risks of rehospitalization in patients already on medical therapy. The Digitalis Investigation Group or DIG trial was a multicenter, randomized, double-blinded, placebo-controlled study of 6,801 symptomatic patients with heart failure and ejection fraction less than 45%. Digoxin did not improve total mortality or deaths from cardiovascular causes. However, hospitalizations as a result of worsening heart failure, a secondary endpoint, were significantly reduced by digoxin. Ivabradine, a funny channel blocker. Remember the name, ivabradine is called a funny channel blocker. Was introduced in 2015 as a therapy for those with chronic heart failure with preserved ejection fraction already on maximally tolerated beta blocker doses, but with persistent resulting heart rates or HRS over 70 beats per minute. In the randomized SHIFT or SHIFT study, it was found to decrease hospitalization from heart failure. It might also reasonable to use in patients with tachycardia who are unable to tolerate beta blocker therapy. Question number 7. What is the suggested dosing regimen of ivabradine? Remember, ivabradine is a funny channel blocker, not calcium channel blocker. Per the package insert, ivabradine is indicated to reduce the risk of hospitalization for worsening heart failure in patients with stable symptomatic chronic heart failure with left ventricular ejection fraction equals 35% or less than 35% who are in sinus rhythm with a resting heart rate more than 70 beats per minute or heart rate equal to 70 beats per minute, and either are on maximally tolerated doses of beta blockers or have a contraindications to beta blocker use. Contraindications to ivabradine include acute decompensated heart failure, hypotension, sick sinus syndrome, third degree heart block unless a pacemaker is present. Resting heart rate is less than 60 beats per minute, severe liver disease and pacemaker dependence, heart rate maintained exclusively by a pacemaker. The recommended starting dose of ivabradine is 5 mg twice daily. After 2 weeks of treatment, the dose can be adjusted based on heart rate. The maximum drug dose is 7.5 mg twice daily. In patients with conduction defects or in whom bradycardia could lead to hemodynamic compromise, the initial recommended dose is 2.5 mg twice daily. Suggested dose adjustment are as follows: heart rate more than 60 beats per minute, increase dose by 2.5 mg given twice daily up to a maximum dose of 7.5 mg twice daily. Heart rate 50 to 60 beats per minute, maintain current dose. Heart rate less than 50 beats per minute or signs and or symptoms of bradycardia, decrease dose by 2.5 mg given twice daily. If current dose is 2.5 mg twice daily, discontinue therapy. Question 8. How do ACE inhibitors and ARBs work? ACE inhibitors inhibit ACE, thus blocking the conversion of angiotensin 1 to angiotensin 2. ACE is predominantly found in the pulmonary and to a lesser extent in the renal endothelium. By decreasing the production of angiotensin 2, ACE inhibitors attenuate sympathetic tone, decrease arterial vasoconstriction, and attenuate myocardial hypertrophy. Because angiotensin 2 stimulates aldosterone production, circulating levels of aldosterone are reduced. This results in decreased in sodium chloride absorption, decreased potassium excretion in the distal tubules, and decreased water retention. Through a decrease in antidiuretic hormone or ADA's production, ACE inhibitors also decrease water absorption in the collecting ducts. ARBs selectively block the binding of angiotensin 2 to the AT1 receptor, thereby blocking the effect of angiotensin 2 on end organs. The net effect of decreased angiotensin 2 on end organs of both classes of medications result in attenuation of sympathetic tone, decrease in arterial vasoconstriction, and attenuation of myocardial hypertrophy. Because angiotensin 2 stimulates aldosterone production, circulating levels of aldosterone are reduced. This results in a decrease in sodium chloride absorption, potassium excretion in the distal tubules, and water retention. Question number 9. What approach should be taken if a patient treated with an ACE inhibitor develops a cough? The answer is non-productive cough related to ACE inhibitors occur in 5% to 10% of white patients of European descent and in up to 50% of Chinese patients. The cough is believed to be related to quinine potentiation. The cough usually develops within the first month of therapy and disappears within 1 to 2 weeks of discontinuation of therapy. The American College of Cardiology or American Heart Association ACC or ASA guidelines suggest one should first make sure the cough is related to treatment and not another condition. The guidelines state that the demonstration that the cough disappears after drug withdrawal and recurs after rechallenge with another ACE inhibitor strongly suggests that ACE inhibition is the cause of the cough. They emphasize that patients should be re-challenged because many will not develop a cough. Suggesting the initial development of cough was coincidental and may have been related to heart failure. Patients who do have ACE inhibitor related cough and cannot tolerate symptoms should be treated with an ARB or ARNI. Question 10. How do aldosterone antagonists work? Answer is ARBs block the mineralocorticoid receptor in the distal renal tubules, thereby decreasing sodium chloride absorption, potassium excretion, and water retention. In addition, they block the direct deleterious effects of aldosterone on the myocardium and may thus decrease myocardial fibrosis and its consequences. Question 11. List the two primary indications of aldosterone antagonist in heart failure. The answer is current primary indications of aldosterone antagonist in heart failure include the following: chronic New York Heart Association class 2 to 4 heart failure and left ventricular ejection fraction 35% or less who are already receiving standard therapy for heart failure, including ACE inhibitors, beta blockers, and diuretics, based on the evaluation of spironolactone in the RALES trials and if and iplirinon in the emphasis EMPSASIS trial. Post-MI patients with LV dysfunction, ejection fraction less than 40%, and heart failure symptoms who are already receiving standard therapy, including ACE inhibitors and beta blockers. EUPHAS study of iflironone, EPAS study of iplirinon. Question 12. What is the recommended dosing of aldosterone antagonist in heart failure? The answer is dosing of aldosterone antagonist in heart failure is as follows: spironolactone 12.5 mg to 25 mg daily, increased up to 25 mg twice daily. Iplirinon 25 mg daily, increased to 50 mg daily. The dosing regimen for aldosterone antagonist in heart failure as well as other medications are summarized in table 27.2. Just look at the table. We will later talk on this table elaborately. Question number 13. Can all patients with heart failure safely be started on an aldosterone antagonist? The answer is a big no. Aldosterone antagonists should not be started in those in whom monitoring for hyperkalemia and renal function is not anticipated to be feasible. It can be started cautiously in men with creatinine more than 2.5 mg per deciliter or women with creatinine more than 2 mg per deciliter. Patients with potassium more than 5 MEq per liter, those not already on other diuretics. Question number 14. Describe common adverse effects of ACE inhibitors, ARBs, and aldosterone antagonists. The answer is common adverse effects of ACE inhibitors, ARBs, and aldosterone antagonists include the following: ACE inhibitors: hypotension, worsening renal function, hyperkalemia, cough and angioedema, which is uncommon. ARBs: hypotension, worsening renal function, and hyperkalemia. Aldosterone antagonist: hyperkalemia, worsening renal dysfunction, hypotension, and hyponatremia. ARBs are as likely as ACE inhibitors to produce hypotension, worsening renal function, and hyperkalemia. Otherwise, ARBs are better tolerated than ACE inhibitors. The incidence of cough is much lower in ARBs, approximately 1%, than in ACE inhibitors, approximately 10%. The incidence of angioedema with ACE inhibitors is rare, less than 1%, more common in blacks, and even more rare with ARBs. However, because there have been case reports of patients developing angioedema on ARBs, the guidelines advise that ARBs may be considered in patients who have had angioedema while taking an ACE inhibitor, albeit with extreme caution. Practically, if a patient develops angioedema while taking an ACE inhibitor, an ARB is generally not initiated. Gynecomastia and other anti-androgen effects can occur with spironolactone and are not generally seen with eplerenone. Question 15. What are the indications for combination therapy with nitrates plus hydralazine in patients with chronic heart failure? The answer is the vasodilator combination of isosorbide or hydralazine I/ACE has been shown to produce modest benefit in patients with heart failure compared with placebo. The combination has, however, been shown to be less effective than ACE inhibitors. The AHEPT trial, which was limited to black patients with class 3 and class 4 heart failure, showed that the addition of I or H, that means isosorbide or hydralazine, to standard therapy with ACE inhibitor or a beta blocker conferred significant morbidity and mortality benefit. Taking all the study data together, the I or ACE, that means isosorbide or hydralazine combination, is indicated in the following patients: those who cannot take an ACE inhibitor or ARB because of renal insufficiency or hyperkalemia, those who are hypertensive or symptomatic despite taking ACE inhibitor, ARB, or beta blockers. The combination of hydralazine and nitrates is recommended to improve outcomes for patients self-described as blacks with moderate to severe symptoms on optimal medical therapy with ACE inhibitors, beta blockers, and diuretics. Question 16. What dosing is used in treating patients with nitrates and hydralazine? Answer is a dosing regimen that is used in treating patients with I plus S, that means isosorbide and hydralazine, is hydralazine start at 37.5 mg 3 times a day and increase to a goal of 75 mg 3 times a day. Isosorbide dinitrate start at 20 mg 3 times a day and increase to a goal of 40 mg 3 times a day. Question 17. How should patients be treated with beta blockers? The answer is certain beta blockers have been convincingly shown to decrease mortality in patients with depressed ejection fraction and symptoms of heart failure. And thus, it is a class 1 indication to treat such patients with beta blockers with an attempt to reach target doses. The beta blockers shown to decrease mortality, their starting doses and their target doses are given in table 27.2. This is the table. We will talk on this table later on. Recommendations from the Heart Failure Society of America and other organizations include the following. Patients should not be initiated on beta blocker therapy during the decompensated or hemodynamically unstable state heart failure. Beta blocker therapy should only be initiated when patients are euvolemic and hemodynamically stable, are usually on a good maintenance dose of diuretics if indicated, and receiving ACE inhibitors or ARBs. Beta blockers should be initiated at low doses, up titrated gradually in at least 2 weeks intervals, and titrated to target doses shown to be effective in clinical trials. Practitioners should aim to achieve target doses in 8 to 12 weeks from initiation of therapy and to maintain patients at maximal tolerated doses. If patient symptoms worsen during initiation or dose titration, the dose of diuretics or other concomitant vasoactive medications should be adjusted and titration to target dose should be continued after the patient's symptoms return to baseline. If up titration continues to be difficult, the titration interval can be prolonged. The target dose may have to be reduced or the patient should be referred to a heart failure specialist. If an acute exacerbation of chronic heart failure occurs, therapy should be maintained if possible. The dose can be reduced if necessary, but abrupt discontinuation should be avoided. If the dose is reduced or discontinued, the beta blocker and prior dose should be gradually reinstated before discharge is possible. Question number 18. What diuretics should be used and at what doses should they be initiated in heart failure patients? The answer is diuretics are indicated for volume overload. Starting doses of furosemide are often 20 to 40 mg once or twice a day, but higher doses will be required in patients with significant renal dysfunction. The dose should be up titrated to a maximum of up to 600 mg daily. See table 27.1. This is the table 27.1, and once again I would like to repeat, we will later on talk about this table. Failure of therapy is often the result of inadequate diuretic dosing. Torsemide is more expensive than furosemide but has superior absorption and longer duration of action. Bumetanide is approximately 40 times more potent milligram per milligram than furosemide. It can also be used in patients who are unresponsive or poorly responsive to furosemide, as it is thought to have better absorption. Synergistic diuretics that act on the distal portion of the tubule, thiazides such as metolazone or potassium sparing agents are often added in those who fail to respond to high dose loop diuretics alone. Question number 19. Should all heart failure patients be placed on statins? The answer is, while statins have been shown to have significant effects in reducing the rate of myocardial infarction and progression of vascular disease in those with coronary or peripheral vascular disease, the benefits have not been translated to heart failure patients with such atherosclerotic disease. Two large clinical trials, CORARONA or Corona trial and the GISSI-HF trial, demonstrated no clinical benefit in the use of statin therapy in addition to recommended medical therapy. Of note, the Corona trial excluded patients with a history of myocardial infarction within 6 months and those with a prior percutaneous coronary intervention or stroke, but is still noted to significantly decrease cardiovascular and heart failure hospitalization in those on statin therapy. The 2013 American College of Cardiology or American Heart Association guidelines do not currently recommend statin therapy in heart failure patients unless there is another indication. Question 20. What is the mechanism of action of digoxin? The answer is digoxin is a cardiac glycoside and is an inhibitor of the sodium positive ion and potassium positive ion ATPase pump in the sarcolemmal membrane of the myocyte and other cells. This inhibition causes intracellular accumulation of sodium positive ion, which makes the sodium positive calcium positive pump extrude less calcium positive ion, causing calcium positive ion to accumulate inside the cell. This effect results in increased force of contraction. Cardiac glycosides also have effects in the central nervous system, enhancing parasympathetic and reducing sympathetic outputs to the heart through carotid sinus baroreflex sensitization. This is the mechanism that underlies the reduction in sinus node activity and slowing in atrioventricular or AV conduction, which makes digoxin the only agent with a positive inotropic bradycardic effect and is the basis for its use in the control of some supraventricular arrhythmias. Question 21. What are some of the relevant drug interactions of digoxin? Answer is, relevant drug interactions of digoxin include the following: quinidine, verampil, amiodarone, propafenone, and quinine used for muscle cramps may double digoxin levels, and the dose of digoxin should be halved when used in combination with any of these drugs. Tetracycline, erythromycin, and omeprazole can increase digoxin absorption, whereas cholestyramine and kaolin pectin can decrease it. Thyroxine and albuterol increase the volume of distribution, resulting in decreased levels. Cyclosporin and paroxetine and other selective serotonin reuptake inhibitors, or simply SSRIs, can increase serum digoxin levels. Question 22. What are the clinical manifestations of digoxin toxicity? Toxicity means poisoning. Digoxin has a narrow safety margin. The difference in plasma drug concentrations between therapeutic and toxic levels is small. Patients with digoxin toxicity may manifest nausea, vomiting, anorexia, diarrhea, fatigue, generalized malaise, visual disturbances, green or yellow halos around lights and objects, and arrhythmias. In the presence of hypokalemia, digoxin toxicity may occur within the therapeutic level. Digoxin dose should be reduced in elderly patients. In patients with renal insufficiency, GFR less than 60 ml per minute, and when combined with certain drugs. To guide dosing during chronic therapy, digoxin levels should be measured 6 to 8 hours after a dose. Question 23. What are the electrocardiographic findings of digoxin toxicity? The answer is digoxin toxicity can result in a variety of ventricular and supraventricular arrhythmias of AV conduction abnormalities. These arrhythmias result from the electrophysiologic effects of digoxin. Increased intracellular calcium uh, positive ion levels predisposed to calcium positive ion induced delayed after depolarizations, and hence increased automaticity, especially in the junction Purkinje system and ventricles. Excessive vagal effects predispose to sinus bradycardia or arrest and AV block. Bradyarrhythmias and blocks are more common when the patient is also taking amiodarone. A specific electrocardiographic or ECG findings include the following: sinus bradycardia, sinus arrest, first and second degree AV block, AV junctional escape, paroxysmal and tachycardia with AV block, bidirectional ventricular tachycardia, premature ventricular beats, bigeminy, regularized atrial fibrillation or uh, atrial fibrillation with slow ventricular response, which is common. Question 24. How is digoxin toxicity tolerated? The answer is it depends on the clinical severity. Digoxin withdrawal is sufficient with only suggestive symptoms. Activated charcoal may enhance the gastrointestinal or GI clearance of digoxin if given within 6 hours of ingestion. Drugs that increase plasma digoxin levels, uh, already which we have already discussed in question number 2020, should be discontinued except amiodarone because of its long half-life. Correction of hypokalemia is vital. Intravenous or IV replacement through a large vein is preferred with life-threatening arrhythmias, but judgment is needed in the presence of high degrees of AV block. Symptomatic AV block may respond to atropine or to phenytoin. 100 mg IV every 5 minutes up to 1000 mg until responses or side effects. If no response, use digibind. The use of temporary transvenous pacing should be avoided. Patients with severe bradycardia should be given digibind even if they respond to atropine. Lidocaine and phenytoin may be used to treat ventricular arrhythmias, but for potentially life-threatening bradyarrhythmias or tachyarrhythmias, digoxin should be used. Dialysis has no role because of the high tissue binding of digoxin. Now, question number 25. What are the indications for digoxin? The indications for digoxin include life-threatening bradyarrhythmias and tachyarrhythmias, hemodynamic instability caused by digoxin, potassium level of more than 5 MEq per liter in the setting of acute ingestion, regardless of symptoms or ECG findings, and digoxin level of more than 10 mg per ml or the ingestion of more than 10 mg of digoxin regardless of symptoms or ECG findings. Digoxin is an antibody that binds to digoxin in the plasma and interstitial space, creating a concentration gradient for the exit of intracellular digoxin. As poisoning of the sodium potassium positive ATPase is relieved, potassium positive is pumped intracellularly with the potential of causing hypokalemia. Thus, potassium levels should be monitored when digoxin is used. The half-life of the digoxin-digoxin complex is 15 to 20 hours if renal function is normal. Serum digoxin concentration rises significantly after digoxin use as tissue digoxin is released into the bloodstream bound to the antibody and should not be measured. Digoxin may have to be re-administered depending on the tissue levels. Question 26. What four classes of drugs exacerbate the syndromes of heart failure and should be avoided in most heart failure with reduced ejection fraction patients? The answer is antiarrhythmic agents as a class are generally contraindicated in patients with heart failure with reduced ejection fraction. Most can exert cardiodepressant and proarrhythmic effects. Only amiodarone and dophytilide appear to have a neutral effect on survival. Calcium channel blockers, more specifically the non-dihydropyridine group, can lead to worsening heart failure and have been associated with an increased risk of cardiovascular events. Only the dihydropyridines or vasoselective calcium channel blockers have been shown not to adversely affect survival and can be used in select patients needing improved blood pressure control. Non-steroidal anti-inflammatory drugs or simply NSAIDs can cause sodium retention and peripheral vasoconstriction by directly inhibiting sodium resorption in the ascending loop of Henle and distal collecting ducts. This can attenuate the efficacy and enhance the toxicity of diuretics and ACE inhibitors. Thiazole diones are developed to increase insulin sensitivity by activating uh, peroxisome proliferator activated receptors or PPARs, which forces cells to increase reliance on oxidation of carbohydrates rather than fatty acids. However, these medications also have effects on the renal tubules where PPARs act to direct sodium resorption in the collecting ducts. They can lead to sodium retention and onset of heart failure symptoms in those without a history of heart failure. Question 27. Is dietary restriction of sodium recommended in patients with symptomatic heart failure? The answer is yes. In general, patients should restrict themselves to 2 to 3 gram sodium daily and less than 2 gram daily in moderate to severe cases of heart failure. Question 28. Is fluid restriction recommended in all patients with heart failure? The answer is not necessarily. Fluid restriction is generally reserved for those patients with advanced or stage D heart failure. Fluid restriction is recommended for patients with 1. Hyponatremia, that means sodium less than 130 MEq per liter, or 2. Fluid retention difficult to control despite high doses of diuretics and sodium restriction. In such cases, patients are generally restricted to less than 2 liter per day. Question 29. Should patients with heart failure be told to use salt substitute instead of salt? The answer is, in some cases, the answer is no. Many salt substitutes contain potassium chloride in place of sodium chloride. This could lead to potential hyperkalemia in patients on potassium sparing diuretics, ACE inhibitors, or ARBs, aldosterone antagonist, and in those with chronic kidney disease or those with potential to develop acute renal failure. Patients who are permitted to use salt substitutes need to be cautioned about potassium issues. There are other dietary modifications such as use of citrus fruits and vinegar that can be used in cooking. Question 30. What are the current criteria for consideration of cardiac resynchronization therapy with biventricular pacing? The answer is the 2012 ACC or ASA Heart Rhythm Society or HRS guidelines on device-based therapy updated their recommendations for those who should receive CRT with a class 1 indication with or without ICD. The recommendations expanded to include those with New York Heart Association Class 2 heart failure symptoms. However, in the CRT for mild to moderate heart failure study published in 2010 by the RAFT investigators, there was also a new finding in those who benefit from resynchronization are predominantly those with a QRS more than 150 milliseconds. Therefore, current class 1 recommended criteria for CRT include presence of sinus rhythm, class 2, 3 or ambulatory class 4 symptoms despite good medical therapy. Left ventricular ejection fraction less than or equal to 35%, QRS more than 150 milliseconds, especially if left bundle branch block or LBB morphology present. CRT may also be considered in those with less prolonged QRS duration, 120 to 150 milliseconds, although benefit is generally not as great and oblique or not as well established. Question 31. Which patients with heart failure should be considered for an ICD? The answer is in the updated 2012 American College of Cardiology, American Heart Association or Heart Rhythm Society guidelines on device-based therapy. The writing group stated that they believed guidelines for ICD implantation should reflect the ICD trials that were conducted. Thus, there are many very specific indications for ICD placement based on symptom class, ischemic or non-ischemic causes of heart failure, and ejection fraction. Because ejection fraction may improve significantly after MI or myocardial infarction as a result of myocardial salvage and myocardial stenting, and with optimal medical therapy including ACE inhibitors or ARBs and beta blockers. Patients being considered for ICD implantation for primary prevention should be optimally treated and have their ejection fraction reassessed on optimal medical therapy. ICD should only be considered in patients with a reasonable expectation of survival with an acceptable functional status for at least 1 year. Class 1 recommendations for ICD include the following. Secondary prevention, cardiac arrest survivors of ventricular tachycardia or ventricular fibrillation. Ventricular tachycardia is simply called VT or ventricular fibrillation is simply called VF. Hemodynamically unstable sustained VT or ventricular tachycardia. Structural heart disease and sustained VT or ventricular tachycardia, hemodynamically stable or unstable. Syncope of undetermined origin with hemodynamically significant sustained VT, ventricular tachycardia or VF or ventricular fibrillation induced at electrophysiologic study. LVEF, that means left ventricular ejection fraction, less than or equal to 35% at least 40 days after myocardial infarction, and New York Heart Association functional class 2 and 3. Left ventricular ejection fraction less than 30% at least 40 days after myocardial infarction, and New York Heart Association functional class 1. Left ventricular ejection fraction less than or equal to 35% despite medical therapy in patients with non-ischemic cardiomyopathy, and New York Heart Association functional class 2 and 3. Non-sustained VT or ventricular tachycardia caused by prior myocardial infarction, left ventricular ejection fraction less than 40%, and inducible VF or ventricular fibrillation or sustained VT or ventricular tachycardia at electrophysiologic study. Question 32. How is advanced heart failure defined? The answer is advanced heart failure is recognized when heart failure patients follow the below clinical patterns. More than 2 hospitalizations or emergency room visits in the past 1 year for heart failure symptoms, progressive decline in renal function, progressive weight loss without other identifiable cause known as cardiac cachexia, intolerance to beta blockers due to worsening heart failure or hypotension, frequent systolic blood pressure less than 90 mm Hg, frequent dyspnea during dressing or bathing requiring rest, inability to walk block on level ground due to dyspnea or fatigue, progressive decline in serum sodium usually less than 133 MEq per liter, frequent ICD shocks, need to escalate diuretic therapy to maintain volume status, usually reaching an equivalent daily dose of more than 160 mg furosemide per day and oblique or need for daily supplemental metolazone therapy. Question 33. When should you consider referral to a heart failure specialist or tertiary center? The answer is referral to either a heart failure specialist or a tertiary care center could be considered when there is concern for worsening heart failure. The mnemonic I need help defined in the table 27 can identify patients for whom this may be appropriate. I means intravenous inotropes, need N means New York Heart Association class 3 B or class 4 or persistently elevated BNP. E means end organ dysfunction. E means ejection fraction less than 35%. D means defibrillator shocks. H means more than 1 hospitalizations. E means edema despite escalating inotropes. L means low systolic BP less than 90 mm Hg, that is tachycardia, and P means progressive intolerance or down titration of medications. Here BNP means B-type natriuretic peptide, BP means blood pressure, EF means ejection fraction, and NYHA means New York Heart Association. Question 34. What are the specialized interventions for advanced stage D heart failure? The answer is stage D heart failure patients with refractory heart failure symptoms despite guideline therapies and irrespective of ejection fraction may have option to either palliate their symptoms or perhaps improve survival. Heart failure with reduced ejection fraction patients may be candidates for either mechanical circulatory support or MCS, for example, LVADs, left ventricular assist devices, or for cardiac transplantation or heart transplantation. Heart failure with preserved ejection fraction patients may be candidates for cardiac transplantation, but at present there are limited options for MCS or mechanical circulatory support for these patients. Continuous inotropes may be considered for palliative purposes in patients who are neither candidates for advanced surgical options nor interested in these surgical options. Question 35. When should palliative care be considered in chronic heart failure? The answer is remember, Furosemide and other diuretics are palliative. Specialty palliative care can be helpful to align patient preferences regarding either aggressive surgical options or end of life decisions. Once again, I'd like to repeat the answer. And the question, when should palliative care be considered in chronic heart failure? Remember, furosemide and other diuretics are palliative. Specialty palliative care can be helpful to align patient preferences regarding either aggressive surgical options or end of life decisions. Question 37, and this is the last question of this chapter, heart failure and the long term management. The question is, what are other implantable devices for heart failure? Answer is, implantable pulmonary artery or PA monitoring has been shown to decrease hospitalizations and mortality in patients with both heart failure with preserved ejection fraction and heart failure with reduced ejection fraction. Transcatheter edge-to-edge clipping of the mitral valve for patients with functional or secondary mitral regurgitation. Interatrial shunt device to dynamically decompress left atrial pressures in patients with heart failure with reduced ejection fraction and preserved RV function may decrease hospitalization. Primary completion anticipated December 2021. So this is all about the chapter heart failure and the long-term management. We talked at large on this topic, heart failure, and how to manage heart failure for a longer time. We have totally talked about 37 questions and the answers to those questions. I hope you did enjoy listening to this and watching this video. And if you like watching this video, if you enjoy listening to this video, please subscribe to this channel. Please make some comments if you want to know more about heart failure. And if you want to know more what is heart failure or anything else, I have uploaded some other videos on heart failure or heart related problems or on cardiology. If you enjoy listening to this, if you enjoy watching this, please watch all other videos and please subscribe to the channel. Wishing you all a good heart, healthy heart, good hygiene, good physique, good emotion, good mentality. Thank you very much for watching this for a longer time.